evening, everyone. Welcome to RSSDI Diabetes Bytes. आप सभी का खूब स्वागत है हमारी इस श्रृंखला में और आप सभी जो हमें रेगुलरली फॉलो करते हैं, हमारे संपर्क में होते हैं, आपको पता ही है हमने हमारे 100 एपिसोड्स की बहुत ग्रैंड सेलिब्रेशन की रविवार को, और हम अभी आगे सीरीज लेके आए हैं जिसका पहला एपिसोड आज है। और क्योंकि पहला एपिसोड बहुत खास होना चाहिए, हमने ऐसा ही एक विषय चुना है जो कि जिसके बारे में कोई भी बात नहीं करता है या बात करने से हिचकिचाते हैं, अपने पेशेंट्स भी और डॉक्टर्स भी। सो आज हम उसका खुलासा करना चाह रहे हैं क्योंकि ये एक खास चीज है जो हमें हमारे डॉक्टर्स के साथ डिस्कस करने में कोई उसमें हिचकिचाहट नहीं होनी चाहिए। एंड we have diabetes and sexual dysfunction that is going to be discussed today, and for that we have a very esteemed panel with us, Professor Deepak Jumani sir. He is a senior sexual health physician and counselor attached to Sir J.J. Group of Hospitals and Grant Government Medical College and Mumbai Police Hospital. He is also the course director and mentor for fellowship in clinical sexology with MUHS. He is a diplomat of American Board Certified Clinical Sexologist, fellow of American College of Sexology, certified sex therapist, and editor for many journals, including the International Journal of Psychology and Counseling. And Sir has had many authored books, articles, as well as is a celebrity speaker at so many of our conferences. With that, I welcome Professor Dr. Deepak Jumani, sir. Welcome to the show. We also have with us a very senior gynecologist and sexologist from the city of Karnal, Dr. Bharti Kalra ma'am. She is a consultant at Bharti Hospital, Karnal. She has a fellowship in clinical sexology, and she's also a fellow of ICOG, fellow of RSSDI, and she's the president of Karnal Obgyn Society, founder member of Diabetes in Pregnancy Study Group India, and co-author of National DIPSI Guidelines on Management of Diabetes in Pregnancy, and has several articles to her credit. Ma'am is also an invited speaker at all national conferences as well as international forums. Welcome, ma'am, to the show. We also have Dr. Mithun Bhartiya from Assam joining us. He's an endocrinologist and has spent several years in the UK. He's also a sexologist and and is also a very close part of the RSSDI Diabetes and Technology Task Force. So with all his varied interests, we welcome him to the panel. I'm sure a chat with all of them, and my co-host, Dr. Faraz Farishta, who's an endocrinologist from the city of Hyderabad. It's going to be a very, very interesting show. So without much ado, let me hand it over to Dr. Faraz, who's an integral part of the RSSDI social media team.
Thank you so much, Purvi. I think, and then let me again welcome all the elite panelists, including you. And I think it is a very important factor that we are going to discuss today. ये मैं कहूँगा एक रोज की बात है जो रेगुलरली डिस्कस होनी चाहिए, लेकिन सोशल स्टिग्मा इतना ज़्यादा है कि इसे डिस्कस नहीं किया जाता है. There is a lot of social stigma which is attached to the word of sexual dysfunction. So to start with, my first question would be to Dr. Deepak. Sir, what do you think are the sexual dysfunction problems? Of course, they might be different in males and they might be different in females. So all these diabetic patients, do they have this sexual dysfunction? And if yes, what are they?
Yes, of course. Diabetes is the sexual health tsunami of our century. After the age of 30 to 35, all diabetics do develop some sexual dysfunctions in the form of erectile dysfunction, inability to get erection or sustain erection for a complete satisfying intercourse, some developed ejaculatory issues, and some developed desire issues. So they have low desire, they become hypogonad. So these are the things which happen in men. And in women, definitely Bharti will enlighten more because she is practicing gynecologist. What I would say from my side, most of the diabetic women have low desire, and
Hello.
most of them have
As these
depression.
disorders. Hello.
Yeah.
Am I audible?
Yes,
Yes,
you are.
yes, you are audible, ma'am.
As these disorders are common in males, but these are also common in females also. The females who are suffering from the diabetes, they have desire and arousal in the first go, and later on, along with it, because of medication and long-standing diabetes, they have orgasmic, and commonly they have painful, means dyspareunia. They get difficulty and pain during sexual intercourse. So these things are common as compared to the general public or general women, those who are without diabetes.
And what we have seen in diabetic women more commonly, when they come with their husband, we find them to be very sad, and there is a depression in them, which is very, very obvious. This is also seen in diabetic women, particularly.
Yeah, I think you've said the right point. Depression. I think this everything revolves around that. So it is a very important to tackle with. So, Dr. Mithun, we now know diabetes. The other D which is being discussed is depression. So, are there any other factors which are leading to sexual dysfunction in a diabetic patient?
Yeah, so you see, diabetes is like a दीमक जो हर चीज को खा जाती है. आपके नस को भी इफेक्ट करती है, नर्व्स को भी इफेक्ट करती है. An integral part of sexual life is intact good nerve supply, and diabetes will affect the nerve supply. It will affect the arterial supply, and very commonly, what I say, is diabetic patients' artery is like Velcro. Normal patients' artery is like silk. The moment you become diabetic, you become Velcro. सब कुछ चिपका चिपका हो जाता है. So your chances increase, the risk of cardiovascular risk also increases. The blood flow is similar pipe flow. There is a jam, then blood is not going to flow in. So there are a lot of factors, as you said, and depression is one, blood flow is one, nerve impairment is another one, and the other factor is also, it's a chronic condition. And I think a lot of it, what happens is failure begets failure. Agar, the Tendulkar is betting and somebody is getting him out in every match, the moment he's going to bat, the ball is going to go in that bowler's hand. So once failure begets failure as well, and that worsens the whole stigmata of the sexual dysfunction, and the patient loses the entire confidence, and the whole ecosystem is disturbed of the house and the family.
Yeah. Coming to Dr. Deepak, is it the risk is same in type 1 and type 2 diabetes, or is it different?
It's almost same, but yes, in type 2 it is more, in type 1 also it is there, but in type 2 it is more.
Coming to you, Madam Dr. Bharti, there is so much amount of stigma which is attached. Even it is difficult for males to express it. So, what is your view on the stigma which is attached, especially when it comes to the females, and how do you deal with it, Dr. Bharti? Ma'am, are you able to hear us?
Dr. Bharti, can you hear?
Sir, it's difficult to.
Are you able to hear me?
Hello.
Oh, yeah.
Yeah, we
Go
can
ahead,
hear
ma'am.
you.
Sir, you are not audible to me at all. Can you
Okay,
read the question?
yeah.
Because I
Repeat
am
the
able to
question.
listen.
Repeat the question, and you share audio no properly. You see, might have been muted.
Dr. Mithun, you want to take that question till Dr. Bharti gets us
What was the
back?
question?
So I was talking about the stigma which is attached, especially, of course, it is in males, but in females, the social stigma, and then how do you overcome that stigma?
Yeah, I think the stigma is in the mind. It's how you're going to, and I think the stigma comes from a person's own upbringing. You see, what you have in when I was there, child, we used to have a cartoon network called Tom and Jerry, and I learned that a cat and dog can never be friends. But when I was in America, I saw all of them playing together. So what your understanding is, what your upbringing is, what you have learned, you bring it on the table in front of a consultation. So I think first of all, the stigmata is both in terms of the patient and the doctors. Doctors have to be more open in asking that. And the dichotomy is that the patient feels कि अगर उसको पूछना है तो डॉक्टर पूछेगा because he asked about blood pressure, cholesterol, examines the feet. But if he thinks it's important, he's going to bring the sexual side of things. And the doctor feels that the patient will bring it. So I think an openness of the environment has to be very, very important. I'll just add another point to the previous question about type 1. I remember doing a type 1 clinic in England, and then the patient को मैं बोला शुगर कंट्रोल करो, ये किडनी खराब नहीं हुआ, ये खराब नहीं, कहता है कि सर tell me what it will affect me now. And then I told the teenager it might affect your sex life. You just turned 360-degree around. So I think with the teenagers,
Yeah.
it's an important factor to discuss and bring it about that it is there, and they're far more conscious about it. So I do write a column
So
called
Dr.
Sugar and
Bharti,
Sex, which is
yeah, please go ahead, Dr. Mason.
Does the menopause make sexual dysfunction more prominent?
Yes.
To this question, I would like to answer. Because of menopause, there is vaginal dryness. So, because of that, the dyspareunia is very common. That is the difficulty in having sexual intercourse. And moreover, because of hormonal influence, the lack of estrogen, that causes the decrease in the desire. Desire and arousal, those things are affected. So that is why the postmenopausal women, especially with diabetes, have more of sexual dysfunction as compared to the premenopausal women. If we compare the women with type 2 diabetes, its ratio is just like in premenopausal, if it is 40%, in postmenopausal, it is around 60% women suffering from the sexual dysfunction.
Thank you, ma'am, for taking out that important point. Dr. Deepak, can we have your opinion? Now we've discussed a few of the causes, the stigma. So how do we manage these patients?
Management depends upon a detailed clinical history of this patient. You need to ask everything in the history, his family history, his personal history, his sexual history, and a detailed history definitely will tell you whether he's got, and particularly you need to be very emphatic with him and try and be very soft and humble and start by telling that you can understand you have diabetes, and there have been diabetics who already have some issues in their bedroom. Maybe they have erection issues, maybe they have ejaculatory issues or low desire issues, and now there is a beautiful treatment for everything, and this can be restored to almost normalcy with the help of maybe diet, exercise, and of course medications. So if you have any issues like that, please tell us. We will try to help you out. So he doesn't feel that he's the only one having this issue, and he comes out of this inertia which he has to talk about it. It's always there in his mind that he's not able to perform, and then he may not come out open on that same visit, but next time when he comes, he will tell you, doctor, last time you asked me, I realized that I have little bit of issue like that. So then he opens up. Once he opens up, then you can ask him about his other histories, like relationship histories, his smoking, his alcohol, his hypertension, get all the investigations done, including hormonal assays, and examining from we examine every patient from top to bottom. We look at his oral hygiene, we look at his feet, we look at his retina, and we do a lot of cremastic reflex, bulbocavernous reflex. We examine the external genitalia, we examine the secondary sexual characters, and after examination we realize, and we do a handy Doppler test also. So we come to know he has got vasculogenic erectile dysfunction, which is maybe due to diabetes or hypertension or due to dyslipidemia. And then we go ahead and discuss with him, send him for investigations, and see what are the levels of his sugars, etc., and what is his blood pressure, what is his lipids, how much is his testosterone, and if he's above 40 or 50, 40 to 50, we try to do his PSA, and then we dish out the treatment accordingly. That's how we manage.
Yeah, I think again you brought out the very important points: psychological, diet, lifestyle, and then yeah, the medication, which does help the patients to a larger extent. डॉक्टर मिथुन, मेरा ये क्वेश्चन रहेगा, हमने ये तो बात कर ली कि हाँ ये कॉमन बीमारी है, पर अगर ये भी सच है क्या कि हर डायबिटिक पेशेंट को सेक्सुअल डिसफंक्शन और इरेक्टाइल डिसफंक्शन होता है या होने का चांस होता है? आपका क्या ओपिनियन है?
आई थिंक जो सी द मेजॉरिटी ऑफ पेशेंट्स या हमारे पास जो पेशेंट आते हैं, या दो तरीका के पेशेंट आते हैं. एक तो वो खुद ही बता देते हैं, एंड द प्रॉब्लम इज इट्स अ टिप ऑफ द आइसबर्ग दैट वी सी. A huge amount of patients, there are, I think studies are on which show the huge amount of diabetic patients have some form of sexual dysfunction. We are not saying erectile dysfunction. They may have early ejaculation, early orgasm, low desire, or a combination of the same as well. So they have certain degree of some kind of sexual dysfunction. Hence, it is important as a clinician, and as Jumani said, we bring about the concept of saying, people don't want to be isolated and saying, "Yeah, tum special ho." You have a special condition. We say it is very common for patients with diabetes to have sexual problems. So, do you have anything like that? But I think one has to be beware that in the clinic, diabetes is a psychosocial, familial, psychiatric condition because the whole family comes. So one has to be careful how you deal with the dynamics of it. But importantly, to have both the partners there, because men overestimates their performance, and the woman will give the reality picture. It is what is happening in the room.
हाँ, I
Can I add something, Faraz bhai?
बिल्कुल बिल्कुल डॉक्टर दीपक, प्लीज गो अहेड.
देखिए, we as medical men know that erectile dysfunction in men is due to endothelial dysfunction. Okay, and the main thing is the endothelial derived nitric oxide, which is responsible for production of nitric oxide, which initiates the whole erectogenic mechanisms. Okay, now there are some diabetics who do not have erectile dysfunction, and they have their HbA1c to 10, 11. They say, no, we are having good enough sex, and it's a fact. And some have erectile dysfunction even if their HbA1c crosses above 7. So there is something, a beautiful study done, and it has been proven that there are variants of endothelial nitric oxide synthase gene. There are 4 or 5 different type of genes. I don't remember the name, but I have the article with me and also some slides with it, wherein certain type of synthetase gene uh, polymorphisms are there, and these are responsible for patients getting atherosclerosis and diabetes and erectile dysfunction. There is 1 or 2 different type of synthetase genes which are present, and these patients do not get any atherosclerosis or get erectile dysfunction due to it. So this is what is to be understood. This is a genetic factor which we need to understand. There are certain genes which allow atherosclerosis, and there are certain genes who do not allow, who do not let the patient get atherosclerosis, and they do not develop erectile dysfunction.
Yeah, Dr. Bhati ma'am, can you take the question? Okay,
I think
Dr. Mithun, yeah, probably you can take the question. We all know, yes, there are drugs which does help the patient. So, what are the drugs, and what are the common side effects? What the patient has to look at?
so. A lot of drugs causes erectile dysfunction, and a lot of drugs can be used for erectile dysfunction. A lot of psychiatric drugs, beta blockers, can cause problems with erection. There's some fluconazole as well, some even anti-acidity tablets can cause. However, it is important that there are drugs which are available, like we call the brand name Viagra, but that was the first because all washing powder is called Surf, all television is called Sony. So like that, everybody believes that Viagra is the only medication that works. There are medications which works like Viagra because that's a common synonym that people understand, that increases the blood flow to the penis, and they have are of various types. It depends upon when the person wants to have sex. Is he wants to have sex on the weekend, has it occasionally? Based on that, the clinician can decide. But there are other things, there are other toxic elements that we take in our body that we can stop, and they will help the patient with erectile dysfunction. Yeah, getting him to stop smoking, getting him to reduce his alcohol intake, getting him to exercise so that there is free flow of the muscles and everything. Because sex is also a physical activity, so one has to be fit for sex. So I think, are you fit for sex is a question that one has to ask the patient and then look at it.
Yeah, I think very, very important that we
About
associate it. Yeah, Dr. Deepak.
for us by about drugs, there are, see, most of the diabetics we see, they have hypertension too. Hypertension per se causes sexual dysfunction in the form of erectile dysfunction, but there are certain drugs which are given for given to these patients for his high blood pressure. They add salt to the wounds. Now, say beta blockers, as Dr. Mithun beautifully said. But one thing we all diabetologists should remember is that when we have a patient of diabetes and erectile dysfunction, there are certain drugs in, if he has got hypertension, we should avoid certain drugs. The number one drug is beta blockers. If we have to give beta blockers, maybe because of his cardiac condition or his palpitations or his tachycardia, we can safely give nebivolol. That is one a beta blocker which is allowed or which has got benefits. It improves endothelial dysfunction, it improves the prostatic hypertrophy, congestion, etc. And it also is a beautiful drug to reduce his blood pressure. So that is one safe. If at all we have to give, second group of drug is diuretics, which we give to our patients. If we have to give diuretics, the safest diuretic is indapamide. So these things we need to remember. Otherwise, ACE inhibitors or ARBs are the best in every diabetics to be given. And of course, calcium channel blockers are the second choice which we can give. But we prefer to give them ARBs. We do avoid beta blockers. We do avoid diuretics. This is what we should realize, and we should take care in mind when we give patients prescriptions with hypertension and diabetes and erectile dysfunction.
Yeah, thank you. Very well said, Dr. Deepak. Dr. Bharti, can you take the next question, please?
The post CABG, the sexual activity can be resumed if the patient's reports are okay and patient is comfortable. So the cardiologist opinion, that is very important. If they permit, and as early as 4 weeks, the person can go for sexual activity. But we should try to avoid medication for sexual excitement and for erectile dysfunction in early phase. And the medication, the short acting medications can be added to it. But if patient is on nitrates, so at that time the nitrates have to be avoided for that period of time.
Dr. Deepak, coming back to you.
The
I was
American
coming back
Heart
to you.
Association says
Actually, I am
that,
unable to understand the question because the volume is very, very low. It's not audible at all. So can I join again? So I think that will be better, maybe.
yeah,
Yeah,
you
Dr.
can
Deepak, you can go
reboot.
ahead. Yeah, Dr. Deepak, you can go
Give
ahead,
me clue
please.
how to get it because
So thing
I
is,
find it difficult.
according to American Heart Association, a patient who's undergone angioplasty can safely start his sexual activity after 2 weeks. Safely, there are recommendations. If he has gone undergone CABG, and if he is not on nitrates, if his wounds have healed completely, his tunnel wounds have healed completely, which takes around a month or two, after that again 2 weeks, and if he's not on nitrates, he can resume his sexual activity. But yes, now they say they should not add PD5 inhibitors immediately, but they can start, their normal foreplay and other things, and see how they can feel. If his testosterone levels are normal, he would definitely have good enough sex, if possible, if everything is okay. But now there is another drug which is available called evanafil, which has got a half life of just 5 hours. And if these patients are not on nitrates, okay, this drug can be given to them. It is that there have been studies which are going on, and they've got getting very promising results because of this drug having half life of 5 hours. And if he's even on nitrate, suppose if he's on a mild nitrate, that nitrate should be skipped on that day, and this can be given after 6 to 7 hours, and then he can take, and this drug also gets washed out within 5 hours from his body.
Change the
So there
clock.
is no hypotension in these patients which we are scared of when we give sildenafil, tadalafil, udinafil, or vardenafil. But with this avanafil, which is now available in the dose of 100 mg and 200 mg, can be given to patients who are on nitrates. But the thing is, we need to remove nitrates on that day, so there is no nitrates left in his body, and then we give him this, which also gets washed out in 5 hours, because the half life is 5 hours and the onset of action is just 15 to 20 minutes. So they can get little good erections and they can perform good enough sex. This is what is the understanding about patients who are having undergone CABG and this thing. But one should be very, very cautious. We should warn them. We should tell them that if he is feeling any choking sensation or anything, or he feels sweating, etc., he can immediately report to us.
Faraz, if I may add, on top of what Bharti ma'am
Please
and
go ahead.
Monali said, my question, and on top of whatever has been said, if you can climb a flight of stairs, then you can climb up the bed, is what I tell them. Assuming everything else has
In
already
fact,
been done.
when the treadmill and all were not there, they were told that you climb 20 steps up and come down 6 times. You are fine. Your stress test is negative. That's what was our old teachers used to tell us. If you climb 20 steps up and down 3 times,
Yeah, I think
your stress test is negative.
Yeah, I think very important clinical point, because we can't put all our patients for stress test all the time. So I think very, very important point. Dr. Mithun, I would like to take up a very important point from Dr. Deepak's talk on testosterone. So we know, yes, diabetic elderly patients do develop hypogonadism. Sometimes we give replacement therapies. So what are the forms of replacement therapies for testosterone which is available, and how long do we give it for the patients?
So you're an endocrinologist for us. You know, if a hormone is absent, we need to give it for life. Okay. The problem is, as you are very well aware, essays are not very good. Okay, free testosterone assays are not available in glucose dialysis. Total testosterone you can use a various scores and adjust and everything. But I think what first before you actually get down to replacing it is the actual patient testosterone deficient, and has the testing been done at the patient? I think that is the sine qua non of the everything else, because everything follows. You know, the whole story follows after that. So I think that is the one point. And yes, there are various replacements. You can give a 3 monthly injection, you can give a monthly injection. There is gel preparation. I wouldn't recommend tablets because they don't get absorbed very well. Uh, it depends upon the choice of the patient. I personally prefer the 3 monthly injection because that's worst that you can do for the patient. Given the monthly injection, there's a yo-yo that is happening. He feels good in a few weeks and feels crappy when the peaks and the troughs happen of the testosterone. But I think more importantly, I mean, I'm just going to repeat that is to make sure that person is actually testosterone deficient. And as a rule, I tell the patient, I'm testing you, 3,000 रुपया लगेगा, but अगर low आएगा, this is a treatment for life. And a few of the patients do back off. So I don't test them then. Because, at the end of the day, it's their money. So people get a little confused as to when they say whether it's for life, they feel it's short-term treatment. Short-term treatment will spoil their access. Hormone access, I do that. Yeah.
Yeah. Dr. Deepak, you want to add something? Yeah, please.
Faraz bhai, Mithun,
Bilkul.
this is definitely a debatable point with endocrine society, with so many other societies. There are a lot of different views. See, whenever the testosterone deficiency is there, it is not sudden; it is gradual. Okay, and I have never seen a patient having zero testosterone. Maybe some with congenital problem, that's different issue. But normal diabetics, they do have 300, 250, 260 like that. So we have certain things besides giving them synthetic testosterone which have now been shown to improve their testosterone, testosterone in the blood. Like my teacher Dr. Prakash Kothari recommends to eat urad ki dal. he says urad ki dal, anar, they and nuts and all, they do improve. And we did try it out at KEM when we saw more than so many patients we saw, and we gave them this, and they did improve in their testosterone. We don't have a scientific study, we don't have a ethical study, but yes, this was our observation which we found. We did not give them testosterone, but the testosterone improved, and with some PD5 inhibitor, they were able to have good enough sex. But yes, I agree. If at all testosterone deficiency is there in a man, replacements has to be for lifetime. But if his testosterone is around 300 or 400, a short course, for 2 or 3 months can increase his testosterone, and then he can, for that time, he can have a very good enough sex life. Again, it might reduce, so we can give him enough. And that's what we used to do, and that's what many endocrinologists do it. They give for a short time and they improve, and again, that because of aging it's going to be less. So but they improve their diet, and then they remove certain endocrine disruptors which cause low testosterone, like excess of beer or plastics or whatever, cosmetics, so many things which are endocrine disruptors which reduce the testosterone, lack of sleep, etc. So all those things, if they follow, their testosterone levels remain to a little better extent. And we need to understand, we need to counsel them for what are realistic expectations of their life. Sex at 70 or 80 cannot be like how you were 20 or 30. So this counseling we need to do, we need to really counsel them, and what is reality, what are your expectations. That's not reality, but this is what you need to do. And then things can be better, they can be satisfied, and they can have good enough sex. See, older people, studies done 70, 80 years, they don't want to have sex every day. They want to have sex once in 10 days, 15 days. That's okay for them, that's fine. They are very happy, they feel connected, they feel emotionally attached. So this is what we need to counsel our patients. I do agree, testosterone, if at all has to be replaced for lifetime. But then we know what happens. Dr. Paresh Dandona did a beautiful study. He replaced testosterone in patients for 2 years. And surprisingly, the functional hypogonadism improved, insulin resistance improved, obesity improved. Beautiful study, yes, and there are several other studies like it. So, testosterone therapy, yes, we know we can get prostatic issues in elderlies, we can get myocardial cardiac failures, we can get in younger patients, which all younger patients who take testosterone come with low sperm count. They get azoospermia, sometimes they get oligospermia. So that is definitely there. So we need to caution them, we need to tell them, and this is what. But even if, my teacher beautifully said that even if he gets cancer of prostate, that'll take, it's the best cancer to get, will last for 5 to 10 years. So that's okay if he's getting at 70 or 80. No, it's not ethical for me to say that, but yes, if at all he gets it, and if he's very 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 stubborn on having sex, so he has to avoid thinking of taking testosterone. This is what is my understanding.
Yeah, yeah. I think Dr. Deepak, you highlighted what I would say Dadi Ma ke nuskhe. Very, very important. We all learn from our clinical practice. There is evidence-based medicine always to support it. But as you rightly said, I think there are certain things, yes, some dietary modifications, physical lifestyle definitely helps in this. There's no doubt in that. Dr.
Yeah,
Mithun, yeah.
yeah. If you just add to that, we did a study in England when I was there. It was the first RCT in primary care population diabetes and testosterone replacement. I think, to sum it up, I won't go a bit longer on it. Testosterone replacement should be done by somebody who is experienced and who is up to date with testosterone replacement. I think that is something, that message I want to make it in one line, because otherwise the goalposts keep changing. The Trevor's trial is out, the T4DM study is out. Trevor's trial will come out next year, cardiovascular outcome. So I think somebody who's on top of it, we should do it, and I think that is what I'm still, either you go full house or no house for testosterone. But we can agree to this.
But Mithun, our experience increases only by working on it. No, it doesn't come inborn.
Sir, I agree to disagree. I've said already, sir.
A new endocrinologist cannot be a person who has got complete experience of treating, low testosterone. You get it over a period of time. You learn from your patient's experiences. You learn from your patient's outcomes. So that's how you gradually. We take opinions from seniors. Yes, We do ask seniors, yes, what do we do? We have so many good senior endo. We take opinions and then we work on it. We are very cautious when we give tests. See, it's a double-edged sword. We need to be very, very cautious with testosterone. It can be a boon, it can be a killer also. So we need to be very cautious. It's a double-edged sword. But yes, you can cross boundaries to some extent in some patients, who really are not in all, but in some patients you can.
Yeah, I think I would here play the devil's advocate role, and then I would say, yeah, I mean, yeah, yes, both the side are very very important, I would say. So, I had to ask Dr. Mithun. We've seen what point has already been got out since the shortage of time. There is abuse of testosterone therapy, which we are seeing in youngsters. So, your views on that? Quick views on that.
As I said, it's simple. Gyms. We should involve gym trainers in the education and people at large. That it's going to spoil your access, and that's why I said short term. In whatever form is going to kill your access, and then sometimes the access takes more than 2 years to recover, sometimes more. So that's why I'm an all or none for one down back. Yeah.
Yeah. So, coming back to Dr. Deepak, I think with the paucity of time, I would like to have your last views on the topic.
Uh, well, counseling is very important in these patients. Do not start immediately with PD5 inhibitors if he's got psychological or situational erectile dysfunction. Yes, all of us, all whom I know, my seniors, they said there's always a psychological component, even if he has got organic ED. So just try to counsel them more. And of course, lifestyle measures should go together along with PD5 inhibitors, if at all we want to give, which is the first line of treatment. But give more stress on counseling and lifestyle measures. Invariably, you'll be surprised that with these two things, they do improve. And if at all you have to give them certain drugs in diabetes also, say oral hypoglycemic drugs, you start with metformin, you start with SGLT2 inhibitors. These two drugs, because of the class effect of these drugs, will reduce the vasculogenic causes of erectile dysfunction, because of these drugs itself. Metformin is now proven to be improving the endothelium. SGLT2 inhibitors, we all know, is a fantastic drug, even given in patients who have prone to heart failures, have increased weight, and they bring down the HbA1c very well, very safe, no hypoglycemia, etc. Little, mycotic infection, that's okay. But the benefits are very good. If you give your patients counseling, lifestyle measures, metformin, and of course SGLT2 inhibitors, and give a sound advice on nutrition, what she or he should have, give them a sound advice on exercise, which is must, and also do their mental checkup. Yeah, and these things will definitely improve his quality of life. If at all, he may improve in his erections little later, but he will be at a lesser risk of cardiovascular disease, which is a very critical event which can go through. And this is the first line is we give PD5 inhibitors to our patients. We have five PD5 inhibitors in our armamentarium. We have sildenafil, tadalafil, udinafil, vardenafil, and avanafil, which is a new kid in the block. So these have got various doses, various onset of actions. The longest you can give is 12 weeks non-stop, which is published data even in diabetologia, irrespective of whatever is HbA1c is, whatever is hypertension is, whatever is dyslipidemia is. You can give him 10 milligram low dose of tadalafil for 12 weeks, and definitely it improves. My friend Dr. Jyoti, they puts these patients on insulin pump, and he found 84 or 85% of patients improve in their sexual functions, which they monitor with these scales which we have. The second line of treatment is if these drugs fail, patients who get side effects like headache, nausea, flushiness, or bluish discoloration, sometimes backache. And so these patients, we can try intracavernous injections of papaverine and largactil, vacuum therapy. If they don't want to take any drugs, we can give them. Then we have intraurethral prostaglandins. And if all these things fail, we send our patients to urologists who treat them with implants or anastomotic surgeries. But counseling, lifestyle measures, giving them proper drugs, psychological counseling, send them to a mental health specialist also if a female is there suffering from diabetes, and see and tell them that this is diabetic woman. Don't put them on SSRIs. The best drug for these patients is bupropion, which they can easily take. We can also give, but yes, we need to partner ourselves with some psychiatrist who could, and an endocrine who can join us and tell us, yes, these are the right things for our patients, they can take it. And that's how we manage these patients.
Yeah, thank you so much for sharing your insights, Dr. Deepak. Your take-home messages, Dr. Mithun.
So very small take-home message. If anything that can come out of this program, please the next time the patient walks in your clinic, ask him, do you have any problem with your system? I think one single take-home message, please start doing that and the rest will follow. I think
The,
that
the
is one
doctors, the
has
doctor
to
should ask only one small question to every patient who's above 30 having a family history of metabolic syndrome, that do you have problems in making love? This is not a vulgar thing. Friends, you will be surprised that your patients were waiting for you to ask this question or initiate a dialogue on this aspect. He may not come on that time, but he will come again to ask you for this. Definitely. And that will be the greatest service you do. Because the onset of erectile dysfunction starts as early as 30, 35 in patients who have got family history of metabolic syndrome. And the onset of cardiovascular disease, coronary artery disease, starts after 3 to 5 years if this is not controlled or if this is not corrected. So you have 3 to 5 years of window period of curability where you can change his lifestyle, give him whatever is necessary, counseling, reduce his smoking, alcohol, ask him to take proper nutrition and certain drugs. He will definitely benefited, and this will be the greatest service every diabetologist can do to your patient, to their patients.
The take home message from my side is the communication is key to success. The communication from the patient side, from the partner side. So if you come to a doctor and you have some sexual problem, must communicate. Try to convey it to your doctor, or you can give the cues, and doctor will pick it up. And from doctor side, it is important to communicate. If you find the uncontrolled blood glucose levels, or patient is her, with the same medication, her behavior is erratic, you should start poking it. Just take a chance that ask her if she has any sexual concern. So communication from patient side, communication from doctor side. Plus, if you communicate very well with your partner, the chances are that your sexual dysfunction will respond automatically. So that is for the message to the community, because the correcting sexual dysfunction helps control blood glucose levels, because psychological stress underlying because of sexual dysfunction that leads to dysglycemia, and the medication's effect reduces. So the stress is to be relieved. So that is why the sexual dysfunction is to be treated. And above all of this is the psychotherapy is very important aspect of the treatment, as sir has already told, plus lifestyle modification and medication change if it is needed for this. Thank you.
Yeah, thank you so much, Dr. Bharti, for getting out all the points. I think you've summarized the entire talk, which all of us have been talking about. So, without taking much of time, I would say it is very important. It is a multidisciplinary approach where a team has to get involved with your patients. And if you are a patient, I think all of them have made it very clear that do talk, baat karo, express karo. This is very, very important, not only to your partner, but to the doctor as well. So at the end, let me thank Dr. Deepak for giving your very important, I would say, experience and sharing your clinical insights. Dr. Mithun, my good friend, thank you so much for getting out, I would say, the evidence-based part, which is again, I would say, very, very important. And Dr. Bharti, thank you so much, ma'am, for taking out, I would say, some sensitive issues which are related to women as well. And then thank you to all of you who are listening to us. Thank you so much.
Thank you,
And see
Faraz
you in
Bhai.
the
You
next
are
episode.
wonderful. You're a great moderator. Thank you very much. It was
Yeah,
Thank
beautiful.
you.
It was wonderful meeting you. Thank you very much,
yeah.
sir.
Thank you. Thank you
Thank
all.
you.
We have to go for our banquet just now.
Please,
Bharti,
please.
are you
Thank you
coming?
all.
Can we leave the studio? We done?
Yeah, yeah, please, please.